So it's 5 minutes after. I'm going to go ahead and begin. We have a lineup today with myself and Dr. Quiñones. We will be discussing how you can use multi-modality imaging in the emergency department setting. So I will go first, and Dr. Q will follow after me shortly. So here's just to kind of set the scene of what we're talking about today, although I'm sure all of you are very familiar with this. This was a 64-year-old female with hypertension, diabetes, presents to the emergency department with chest pain. And initial cardiac enzymes are normal. And here's her EKG, doesn't look too exciting, and a chest x-ray. And the question that we're often left with as physicians is, Rusha, what would you like to do next? So this is kind of what we're left with, you know? I mean, this is what we do on a daily basis. Are we going to, send this patient home? No. Are we going to perform some sort of functional test? And is it going to be without imaging, just a straight treadmill, or are we going to do some test with imaging involved, or are we going to go for an invasive angiogram? So these are the questions, and then when the test we have many different tests, and being fortunate at Methodist, you can order any of these today on these patients. What should you do, or what do the guidelines recommend, or what is our pathways? All interesting questions that we can kind of discuss. So acute chest pain turns out to be a very, very common cause for people presenting to the emergency department. Turns out to be the second most common cause. Lots of visits all throughout the country with a cost of almost $10 to $14 billion. What's so interesting about this is the vast majority turn out not to have ischemic origin chest pain. And in fact, only less than 5% of patients actually have something real. And what the big dilemma is for a hospital system in today's environment is speed versus accuracy. You don't want to miss a myocardial infarction, yet at the same time, you don't want to perform a lot of hospital testing, which keeps these patients, jammed in the emergency room where you can't get patients through the emergency room. You don't want to necessarily admit them, and leading to additional costs. So this is a real issue and a problem for every health, hospital system throughout the country. Now, in general, it's agreed upon that, we know that patients who are inadvertently discharged with an ACS have a very high morbidity and mortality. And at least from the readings that I've seen, a target that the ED community would like to achieve is having a less than, whatever we do, having a risk of missed ACS of less than 1%. So if we do here at Methodist exactly what the guidelines pretty much recommend currently. These are the 2014 guidelines on management of non-STEMI. It basically says, that if you have a patient comes in with chest pain, they have a normal initial EKG and a normal initial troponin, you're usually putting them in some unit, where you can monitor them closely with telemetry, a chest pain unit, get serial EKGs, do some serial cardiac enzymes, and then you have a choice after that. At least within 72 hours, you can either send them home if you feel they're very, very low risk and without quick outpatient follow-up in 72 hours, or you can go ahead and proceed with some sort of testing, and they recommend everything that I showed you the slide of. Treadmill EKG, stress myocardial perfusion imaging, stress echo, you have your pick. And then on number 3, they also say, well, there's a lot of data with CT, which I'll share with you. And they said, okay, you don't necessarily need to get more serial troponins. You can go straight to CT, go that route, because that's how that technique was studied, or do a rest myocardial perfusion imaging. And we'll talk about that. And all of this is really to further risk stratify your patient to prevent you from missing anybody, inadvertently sending someone home who has true ACS. But, you know, despite everything that we do and all the testing that we do on the patients, you know, again, only 1 to 4% of these patients have angiographic evidence of chest pain or of CAD. So obviously, there's a lot of room for improvement, and you know, we'll talk a little bit about that. So a lot of this focus is, you know, this is a multi-modality imaging conference, so we're going to talk a lot about the imaging that's revolved around the setting of acute chest pain, and then we can talk about the future. So exercise treadmill testing, you guys know it's recommended. It's part of the guidelines. You can use it if you want. It's generally recommended after a second negative troponin to make sure they're truly not having an event. It has been well studied. In over 3,000 patients, the prognostic data is very, very strong with an exceptionally high negative predictive value for acute coronary syndromes. Obviously, it has some disadvantages in this ED setting. You know that we have a lot of patients who are elderly, you know, they've got hip problems, back problems, they may not be able to get on a treadmill. If they have any baseline EKG issues, abnormal EKG already, that's further difficulty that can in your evaluation of a stress ECG. And then finally, it's great for prognosis, but we all know that it's not the best test for diagnosing CAD or detecting CAD. And this is just a very large study that goes to point that out. You know, meta-analysis of 147 studies, 24,000 patients, mean sensitivity, 68%, specificity, 77%. So really not the best test. We know it has issues in women, especially, and hence why we often add imaging, and especially as we do in our center. So when it comes to imaging, you have these are again supported by the guidelines. Really, the choice of testing really depends on your local expertise and the technologies available. We're blessed we have all of them here. You can use exercise or pharmacological. And studies have shown that, you know, prognostically wise, again, all these techniques have extremely high negative predictive value for making sure you do not miss ACS. And compared to the treadmill, they're much more effective at detecting CAD. And in general, most of these studies have similar, other than CTA, which is the most sensitive, most of these have similar sensitivities and specificities. Additional information you get from these tests, of course, are knowing about the ejection fraction of these patients, the location and the extent of ischemia, which can all have important things on prognosis. And then some of these tests can also detect non-ischemic causes. So another advantage in the ED setting. So let's begin with, you know, historically one of them. This was rest myocardial perfusion imaging. I know probably, I don't imagine you have seen, at least I can't remember the last time it was ordered in the reading in the nuclear lab, so I don't think any of y'all may have seen these studies. I remember doing this when I was a fellow on a few patients. And basically, these are patients, if they present to you in the emergency room with active chest pain, they have to have chest pain of very close onset to when they get their radiotracer. You can inject them with rest perfusion imaging, get them to the lab and image them and look for a perfusion defect. Because the idea is, remember the ischemic cascade, that if they have a perfusion abnormality at rest, with chest pain, you know, they could very well have ischemia. Obviously, there's caveats to this, that if they already have a known history of myocardial infarction, obviously they'll already have a perfusion defect and it's not going to be diagnostic in that setting. But, you know, in the correct patients, this has been studied in multiple studies and has a very high negative predictive value in detecting myocardial infarction. And there was a large trial called the ARRACE trial. This was definitely on the nuclear boards. So this was a study where they randomized patients to rest myocardial perfusion imaging or standard of care, be it whatever it was. And the primary endpoint was whether it improved your clinical decision making. And what they showed in this large trial in multiple centers, that it definitely reduced the rate of admissions in those patients who had rest myocardial perfusion imaging, and that at 30 days, there was no difference in MACE between the two strategies. So it works. What about stress arrest or stress-gated myocardial perfusion imaging? This is what you are normally used to doing when you order a nuclear study. This is one study, that looked at this. A large study of 1,500 patients randomized to stress myocardial perfusion imaging or standard of care. And the story will be the same in all of these, that a very high negative predictive value for detecting a MACE and compared to the standard of care group. We ourselves also looked at this, and we did a large trial here, 1,500 patients, prospective observational trial. All of these patients had nuclears. These were low to intermediate risk patients by their TIMI risk score and their clinical profile. Vast majority got, in this particular study, adenosine. We only found an abnormal SPECT rate of 9%, and this again has been reported in the literature. And most patients had a normal ejection fraction. And again, similar to every other trial, if you have a normal myocardial perfusion study, your patient is going to do very well. So these tests have very high negative predictive values, which give you the confidence to send your patient home safely, knowing that they're not going to come back with a bad event. And the overall event rate in our trial here was 5%, and you'll see that this goes along with what I had shown you in the introductory slides, where there's a vast majority of patients don't have disease and only around 5% do. And you'll see this in whatever trials we have done here, this consistent number. This trial also went on to show that you can actually, categorize your risk of your patient based on their perfusion defect size. So both their total perfusion defect size and the amount of ischemia. So just showing you that you can further risk stratify patients that way. And finally, this one final slide, showing you that it definitely having perfusion imaging did add to your global chi-squared, so it definitely did add in addition to your clinical findings and your TIMI risk score. And we weren't the only ones who did this. This is now accumulation of data looking at SPECT in the emergency department. You can see a very large number of patients, and if you look at, again, the negative predictive accuracy, in the ED, you want to have confidence in sending the patient home. So you don't want, to miss any true disease. And you can see here the rates are, 99s and above. All right, so moving on to CT angiography. This is also a field that has a lot of data in the ED setting. Remember, this is a technique now that, unlike the other techniques we discussed, provides more anatomy than functional information. And really, this question has been answered by 4 very large trials for a total conglomerate of almost 1,900 patients. They compared CTA to either nuclear imaging or standard of care. Standard of care was, whatever the physician chose to do it, be it treadmill, nuclear, or echo. And some follow-up, usually in the range from 30 days to 6 months. Again, looking for MACE. And again, just to show you who this patient population is, you'll see in the ED setting, it's usually the low to intermediate risk patients. Remember, high-risk patients, people with positive troponins, positive EKGs, they're headed to the lab anyways, cath lab. So these are usually patients, again, who have normal EKGs, normal enzymes. They tend to have this a low to intermediate TIMI risk score, tend to be generally younger. And what you found in these studies that if you used CTA compared to those who underwent standard of care, there was no real difference in death or myocardial infarction. So at least a conglomeration of 4 different studies shows you that this technique is safe, that you can effectively use it. It did show some other things that were interesting. It showed that if you use CT, you can actually process patients faster through the emergency department. So what you'll notice is your time to diagnosis was reduced. You can see in all the major trials, it was reduced anywhere on the order of about 50% of time. That led to less time in the emergency department, and of course, that translates into less emergency department cost. So hence, this was maybe a possible advantage for hospital systems, is that you had a technique here where you could maybe, has not only safety profile associated, but you can process patients faster. And this is just a graph showing you that in those arms in one study compared to standard of care, you can see patients who have CT tend to, we're getting their CTs done, and we're going home a little bit earlier. Now, it did show in these conglomeration of 4 studies that, despite patients with the use of CT, remember it's an anatomical test, obviously you're identifying anatomy. This can lead to an increased use of invasive coronary angiography, because this was pre-FFR days, CT-FFR days, so if you were seeing moderate lesions, they may go on to the cath lab for further assessment. And they also noted a trend that compared to standard of care arm, it was leading to increased revascularization. But at least one study that has looked at total hospital costs, there was no difference, but this is just one study. A lot of data needs to be, there's really not too many good studies out there that look at overall costs in the long run of how patients are dealing with a normal nuclear versus a normal CT. All right, so then of course the other issue is that, what does a normal CT mean? And this is one paper from, again, in the ED setting, showing you the value of a normal CTA here in the blue dashed lines. You can see if you have a normal CTA, you can be very, very confident, again, that your patient is not going to have an event when you send them home from the emergency department. Obviously, if the study is abnormal, these patients have a greater likelihood of MACE. Now, what was interesting from this study, and we'll come back to this issue, was this was also a time where they showed you can see the green line. The green line are patients who have non-obstructive CAD. So they may not have had a stenosis present on their CTA, but they had evidence of atherosclerosis. And you can see their event rates are not the same as somebody who has normal, pristine coronary arteries. And so I think, that is one strength that needs to be mentioned about CTA, is that, remember, this is the only technique that shows you atherosclerosis. So, and within the CT literature now, we have ways to, describe this: calcified, non-calcified, lipid-rich. We know types of lesions that predispose you to ischemia and the risk of acute coronary syndromes. So most important point, this is a technique that you can actually see atherosclerotic plaque and act on it and maybe change this patient's prognosis for the future. And so, and you would hope that patients get this information. I was having a conversation with Dr. Zogby earlier that, as interpreters, we have to really make sure our referring physicians understand these patients have atherosclerosis, because we want them to prescribe these medications, the aspirins, the statins, the risk factor modification, because there's so much data there already. This is now data in stable chest pain, but why would it be any different for an emergency department? That if you use your CTA and you treat your patients aggressively, if you identify atherosclerosis, 4 trials, large trials already have shown now that you reduce your patient's risk of myocardial infarction by an aggregate of 31%. So, we need to act on the data we're receiving. So another potential strength of CT in the emergency department. We ourselves also looked at the CT scans versus standard of care, which was in our institution SPECT imaging. We randomized about 600 patients between CT and SPECT imaging. All the patients who had CT had concomitant calcium scores. In this study, about 54% of patients who were in the CT arm had a calcium score of 0. Our study was also unique in the standard of care arm that at this time we were using stress-only imaging. So we had a large group, almost 25% of patients were having stress-only imaging in the emergency department. And we did the usual length of follow-up, which was here around 6 months, to make sure the strategies we were using were safe. And specifically in this study, we were interested in, again, length of stay. The event rate, remember our last study was around high 4s. In this study, we were consistent again with around a 4% event rate. And again, the baseline characteristics, I'm not going to spend too much time on this, very similar to our last studies or all the ED studies, which are really a low to intermediate risk population. And what we showed in the study was that, again, if you have a normal, similar to data I've already now shown you, but I'm just showing you our own data, that if you had a normal SPECT or CTA, both of these patients did equivalently very well without major adverse events in follow-up. Whereas as soon as you had an abnormal study, your risk progressively increased. But what was interesting about our study was we looked at length of stay and, yes, sir.
And did any of the patients with 0 calcium score have an event?
Yes, coming up.
Coming up?
Okay, so what we did in this, so the interesting data from our study that was different from what was already published in the literature, those 4 trials that I showed you, was that what was similar was that, again, we showed CTA was faster than the all SPECT group. So, you know, if you looked at both those who are having stress and rest and those who are having stress only, CTA was faster. But what was interesting was in the 25% of patients who had stress-only imaging, CT was, stress-only imaging was just as fast. And so this was one of the first times this was shown in the literature, that like with any technique, you know, if you can, that using stress-only imaging, you can achieve a fast throughput through not only your lab, through the ED, and get these patients home fast. So for the first time, it was shown that, you know, with nuclear imaging, specifically stress-only imaging, you can move patients faster.
And it's not surprising either because you have one test.
You have one test.
You could do the same thing for a stress echo, a stress ECG, a stress test of any kind, or a CTA.
Correct. Correct. And this is, again, similar curves that I've showed you in the past, but the more up and to the left that you see, those are, again, CT and stress-only imaging. They would go home faster with decreased length of stay. Other things that we showed were, again, these are moving targets that in general, you know, our CTA population as an aggregate had a slightly higher radiation dose than our nuclear aggregate. But if you, this was the days of 64 slice CT, if you're doing prospective CT scanning, you were getting about 5 millisieverts of radiation. And if you compared that to your stress-only imaging, you were getting 5 millisieverts of radiation. So not only showing you stress-only can send people home just as fast as CT, but you know, you can send them home with much less radiation as well. Okay, and so in this study, we also had this group of patients, almost 50% of patients had a calcium score of 0. And we observed in this study that almost, you know, none of them had any events in follow-up, and that there were no patients who had a stenosis greater than 50% by angiography. So, you know, this was a great observation and leads me to, and you know, therefore, when we compared these different techniques, SPECT, CT, and calcium scoring for their negative predictive accuracy, they all fared just as well. So
you had a prior study with what was the soft?
It's coming up. I'm leading y'all into it. It's coming. Okay, so stress-only imaging, again, showing you that it has the value that we discussed. Before I get to the calcium scoring, you know, I wanted to mention MRI. There's been 3 studies of MRI that in the emergency department setting all have shown that this is a very viable technique as well. Without any difference in MACE compared to a conventional group or a usual care in follow-up. So this is also a technique that can be done and has been studied. Of course, like echo, it has the advantages of being able to identify non-ischemic causes of chest pain. What about cardiac PET? Talking with Moaz, there's not much data out there for acute chest pain like there is in chronic chest pain. But we know the strengths of PET. We know its resolution, quality, its high diagnostic accuracy, the ability to quantitate flows. We know it's a fast technique with less radiation. There should be no reason that it wouldn't be effective in the ED setting as well. And then finally, that brings us to calcium scoring. We know from a lot of data that calcium scoring is representative of total atherosclerotic plaque burden. And we also know the power of zero. The power of zero is these patients who have a calcium score of 0 do not have abnormal stress tests. They do not have significant CAD by angiography, and they do not suffer myocardial infarctions. And this has been shown repeatedly in the literature. So one of the studies that we designed was we had about a cohort of in the chest pain patients of about more than a little over 1,000 patients who had SPECT imaging, but we combined that with a calcium score and followed these patients prospectively. And again, same low to intermediate risk patients with normal EKGs and negative cardiac enzymes. And what we found was that in the SPECT population, as has been shown in numerous other studies, more than 96% of studies were normal, whereas there was only a 4% abnormalcy rate. And again in this study, remember in our last study, it was a 50% calcium score 0. Here in this study, 61% of patients had a calcium score of 0. And if you look at the relationship between calcium score and SPECT in this cohort, you will see that as the calcium score increases, your progressive risk of having an abnormal nuclear increases. Similarly, if you look at the relationship for events, which was death, myocardial infarction, and stenosis greater than 70%, you observe similar relationships. So that as your calcium score increases, your risk for MACE increases. The combined event MACE in this population was 3%. Again, consistent between the 3 to 5% shown in our publications and by other groups. And then again, nuclear showing a very good diagnostic accuracy with abnormal studies having patients with events. When we looked at, again, the negative predictive accuracy, SPECT again was as very predictive. You can confidently send patients home with a normal nuclear. But what was interesting was if you had a calcium score of 0, it had slightly higher negative predictive. It was almost 99.7%. It had an extremely high negative predictive accuracy for detecting MACE in follow-up. So, this body of literature is building then, and if we look specifically a little bit closer at the calcium score of 0, we had 5 patients who had an abnormal SPECT. 4 of them had normal caths. 1 just had medical follow-up and was without any events. So at worst, there was a 0.16% event rate. There were 2 patients who had cardiac events. Both of them were troponin leaks that were not further worked up, and they had no events in follow-up. So, this has been extensively now looked at in the literature, looking at calcium scoring in the emergency department. Our prior study that I had mentioned can be added to this population to get almost a population now of 2,500 patients, where, again, the negative predictive accuracy for predicting events in the emergency department is as good as any technique. So, we can hopefully one day simplify our chest pain algorithms. And there's small group studies out there that have looked at long-term prognosis, and as you would expect, those who have calcium score 0s continue to do well, and at least in the asymptomatic population, do well out to 12 years.
Quick question. So the calcium score is asymptomatic, 0, and what else? What's the next big step? Is it 0 to 400, 0 to 100?
Okay, yeah, it's 0 to...
Repeat the question.
Sure. I think Steve is asking what are the ranges of the calcium scoring. So 0 to 10 is considered minimal. 0 is normal. 1 to 10 is minimal. 10 to 100 is mild, 100 to 400 is moderate, and greater than 400 is severe. The greater than 400 severe, just like we had shown in our data, these patients have anywhere between a 25 to 40% abnormal C-SPECT rate. So you can actually detect ischemia on these patients.
So the prognostic steps, it's not linear at all. Because one, I asked this, my neighbor had one of these this week, approached me in the driveway with his score of 1. And, you know, but the bottom line summary is that you're at increased risk because his score was 1. And I'm thinking, 1's a lot closer to 0 than it is to 10.
Yeah. In general, you know, we're detecting, when we look at, when you detect calcium, you're detecting at a ratio of 1 to 5 of the non-calcified plaque that's present, also present. So, you know, there's 5 times as much non-calcified present for the score that the patient has. So yes, he has some non-calcified plaque, but he may very well have a lot of non-calcified plaque.
There is also an age factor, which I don't know if applies to your neighbor, but at my age, if I have 1, I'll celebrate tonight. In fact, if I have 10, I'll celebrate tonight.
Yeah.
But if you're 48 years old and you have 1, you know, and you're looking at a lifetime, that's a whole different ballgame.
Yeah.
So I think the age factor is very important.
You
because
can calculate percentiles and to give you a feel for your patient's age. Overall, in general, the overall score is predictive. This patient is at very low risk, but Dr. Q is also right. Obviously, if he's 30 with already showing evidence of disease present, I think we'd all take that patient very differently. The guidelines at least give it, you know, when they consider lipid therapy, percentile greater than 75%. You can consider treatment.
So is your summary statement that appears with that test, does it factor in age in the risk calculation?
We often report percentiles, yes.
Always.
Okay, so I don't want to, okay, so take-home points, a lot of patients coming with chest pain, multiple studies showing all of these imaging techniques are great. So what does the future hold? Maybe I had asked Rusha and shown her that slide of all the tests. The future may hold that we're not going to do any of these tests. So there are a lot of clinical risk scores, and a lot of them you've heard of, TIMI, GRACE score, but 2 of the more recent ones, if you've been keeping up with the literature, are this ED, assessment of chest pain score, EDAX, I guess, and the heart score. And they look at the age of the patient, some sort of clinical profile of what risk factors they have, types of symptoms or symptom quality they have, and that people are trying to look at and may or may not add a troponin to it. And they're trying to figure out who we can just send home from the emergency department, period. And so these have now been studied. This heart pathway, if you use this, at least in this study, they had about 3,000 to 4,000 patients in this study. They had a less than 1% MACE, so they met the target that the community is trying to achieve for. And this was simply with calculating this heart score, which is done based on clinical parameters, and then checking a troponin and figuring out, just with that algorithm, you can send this patient home. Similarly, other groups have said, and again, here the Europeans are again leading in this. They have 3R pathways where you take a combination of these clinical risk scores, and in this particular setting, they're using high sensitivity troponin. They can clear a patient in 3Rs. In fact, the ESC even has a 1R protocol. And basically what you're doing here is these patients come in, you calculate the score, you combine this in conjunction with a high sensitivity troponin, and you're making a clinical decision. And if you look at the study, in both of these, in this particular study, it was shown that this high SDAX pathway was more effective than the ESC 3R pathway. But if you have a score that's low with a negative high sensitivity troponin, these patients are bulletproof in follow-up. So there's a lot of literature, and all of these articles are from 2018. There's a lot of literature now that we may very well in the future not doing any of these testings, at least in an inpatient setting, and sending him patients directly from the emergency department.
So that HARP strategy, the score volume component, that's been the Canadian model for 20 years. There's no such thing as an ERC.
You guys didn't publish it. Okay. All right. And so anybody who wants to know a little bit more about these models, you can see here, it's just age, EKG findings. They really dig into a little bit of the risk factors and the type of score, chest pain that you're having.
No, but the amazing thing is, to start with, your data has shown repeatedly, and it's not only particular to Houston, that this population is a low risk, to start with.
Low risk, yeah.
I mean, if 96% or 94% of your stresses are normal, I mean, that's almost lower than even the general population without chest pain, right? So this is where, yes, defensive medicine is at play, and the defensive is not from the cardiologist, it's from the ED, situation, and having something to give more confidence and more accuracy, I think, for people. And the question is, are you aiming for 100%, which will never occur?
Correct.
Right? So, to start with, the question is where calcium scoring here fits in. You have to wait for a troponin for some time. You see what I mean?
These are just clinical risk scores.
No, I'm saying because this is such a simple test, right? And it's almost half of your population that you could do and see whether you could refine this thing. Because it's in and out. You don't need an IV. You don't need anything. You're just like, you're in and out, and see is there calcium, yes or no.
This was
It's as simple as that.
As simple as that. This was another paper, 2018. This was retrospective, needs to be studied prospective. You may say, well, we don't have high sensitivity troponin in our hospital. They looked at a modified heart score, so they modified one of the variables, and they looked at cardiac troponin I. And if you have a low risk score by this modified heart score and your troponin is normal, you're bulletproof, and you're going home. And this was studied in 118,000 patients in the Kaiser system. So I think, the guidelines definitely are going to have to take into account these clinical risk scores. I think we're going to be doing things very, very differently in the future, and we may not be doing a lot of imaging in the ED setting. Dr. Q, please give us the final words.
So I'll start by saying that I agree with everything that Faisal said. And let me just go ahead and get my... All right. So my humble opinion is that the only reason we are not doing calcium scores routinely in the ED today is political. It's a push for other people that want to make more money. We don't need a randomized trial. I mean, my God, 2,500 patients, how many more do you want? But, the radiologists want to push ETA because they make more money. Most of those ETA trials were not cardiologists, they were radiologists. It's chest pain is a good source of income for hospitals. So my personal biased opinion is that we could have been doing calcium scores a long time ago and sending people home. So I'm just going to have a few slides about echo. We already talked about the fact that this is a low frequency of significant etiologies, but they can be catastrophic if you miss them, and the fear of death and the fear of lawsuits is what's triggering all of this conversation that we have just had. So this is currently what we do, right? If they have no clear etiology, they're observed, and then something is done, which Faisal presented beautifully. And these are the choices, and they're all approved, appropriate, as Faisal said. I think it's important to remember, though, because all of you, when you finish your training, you're not going to necessarily go to a Houston Methodist hospital setting. Some of you may end up in some sort of smaller community, and stress testing does play a role. I think Faisal showed it very nicely. sensitivity and specificity for disease are not the best. But if somebody exercises well, the prognosis and the DO score has a very low risk setting, these people do very well. So that I think have to remember, because when you go to a community where you're practicing perhaps in a 100-bed hospital, you might have a nuclear medicine guy doing the nuclears, a radiologist with CTs. It may be on you to make some decisions. And I think it's good to know, regular treadmill still works. And this is where perhaps also echo may be of some help. So the role of echo in this setting really is stress echo. I mean, that's truly is the real role. And we had a whole hour on stress echo a few weeks ago, so I'm not going to go through all of that, but it's the same as what we described, right? Stress echo is a very powerful tool. We can detect ischemia, we can look at abnormalities at rest that points out to previous injuries, and so on. And we showed something like this a few weeks ago, and this is a gentleman that had multivessel disease, post-exercise, significant reduction in global function, and a lot of regional changes. Both are available. However, as I pointed out a few weeks ago when we did the stress echo lecture, Dobutamine stress echo is not as accurate as pharmacologic SPECT for several reasons. We pointed them out a few weeks ago, particularly with smaller hearts, hypertensive people that have LVH. They can become so very hyperdynamic that you cannot pick up ischemia, even though they do have it. So again, if you're in a smaller community, and if that's all you have, you may have to work through it and recognize that you may have certain amount of false negatives. The false positive rate with dobutamine versus exercise, they are comparable when you look at large databases. I think the biggest concern is sensitivity with some of these. However, there's literature in dobutamine stress echo in this setting where people are sent home if normal, and they have a relatively low risk also within the first 6 months. So my own bias is I would use dobutamine stress echo if I'm in a practice in some hospital that I don't trust in nuclear or I don't have access to the others. Certainly a calcium score would be better. And this is just data from stress echo that I showed you this slide earlier. And the important thing, again, is the impact in prognosis, that they're very powerful, just like all the nuclear techniques. And if you combine wall motion with the treadmill data, I showed you this slide a few weeks ago, then you even have a more powerful tool for looking at prognosis, because not only you have the exercise wall motion index, but you also have ST changes and duration of exercise, and then you combine all that data to have a more powerful prognosticator. And this is obviously a nice example of a positive dobutamine. When positive is very nice. The question is, how sensitive is it in certain settings? And the most tricky setting, I think, is A, left bundles, where you have both false positive and false negative, and B, small hypertrophic ventricles. They can be tricky. All right. They're all appropriate. The point I want to bring in, just because we're doing so much of that in this hospital, is the role of a resting echo. And I think a resting echo really has a limited role and should be reserved for people that have very specific things, i.e., if they already have abnormal EKG, particularly EKG changes that suggest a cardiomyopathy or a previous infarct, yes, you would like to know more about ventricular function, wall motion, diastolic function, and so on. They have dyspnea, it's obvious. If they have already known CAD with previous MIs, likewise, you may want to use the echo to assess these findings. And if it smells like pericarditis, no question about it, that a resting echo would be very appropriate. But if you look at the demographics of what Faisal just showed you earlier in terms of the whole distribution of chest pain in the ER, what % of patients fall in this group? 10%? And if you look at the number of people that are put in observation and getting resting echoes, and then they're in panic calling you for stat because they want to send them home, it's ridiculous. But anyway, somehow we need to try to do something about that. But that's the way it is right now. You get that, that's nice. You can find that, and those people usually have findings that are quite important. Okay, so what I'd like to finish with, I think, is restating what Faisal said earlier. I think there is a lot of data coming out with the very sensitive troponins eye. These are people, all of these people have had either infarct or ACS. This is unstable angina, and this is nothing, no cardiac cause. And you can see that there's a threshold here that puts a big separation of the people. And then there's been multiple trials. This is one of many. Faisal even showed you a more recent one. This one has 66,000 people. He showed you data from over 100,000 people. So the Europeans really have been ahead of us on this, and clearly showing that when you have normal high-sensitive troponins, you really are in a safe grounds. So if you combine that now with the clinical evaluation of the patients using some of these protocols that are being suggested, truly, I agree totally and 100% with Faisal that most patients should be able to go home within a couple of hours from the ED without having a lot of expensive testing. So I think the day may come where we may have the patient come in, and depending on the use of the algorithm, including history, exam, EKG, and troponins, then be able to send a bunch of people home, and then place in observation or admit those who truly now are targeted. And if we did that, I think we should have, at a national level, had a major reduction in cost without any true increase in risk. And I hope somebody takes the lead on a national level to start pushing this, because this is truly one of the highest causes of cost for everybody. We keep talking about cost for the hospital, but most patients now have insurance plans that when they go to an ED, they get killed by their copays. So this is not just good practice for the hospital, it's good practice for the patients too, and for their pocket and for their families. So I think this is a situation that I hopefully through, maybe, I don't know if the college could take a leadership on this, but somebody has to take a leadership and bring a panel of experts together, do a good study, and then present it and try to convince insurance companies and the whole system, because everybody's in so panic mode about being sued if they miss one patient in 1,000 that they don't want to, they're paralyzed. They don't want to do anything that is new and less costly. So I think we're good for a few minutes for questioning. It's a topic that can generate some discussion. So I'll stop right here, and we have some time for questions for the fellows, and yeah.
Just a comment. By the end of this year, there's going to be an update of the stable chest pain ACC guidelines, and I think they're going to follow probably the Europeans and endorse more for CTA, but it's coming actually, I think.
But that's stable chest pain. That's what we see in the clinic.
Yeah.
Yeah, which is not the same as the ED.
Yes.
Yeah.
There's going to be an update later this year.
I just want to add one additional.
Pass it on.
There's one additional trial for CT in the emergency room. It was done in the Netherlands, and that one compared CTA to a cohort that used high sensitivity troponin. And the benefit of CTA over in usual care utilizing high sensitivity troponin kind of wiped out.
Yeah.
So the time to discharge was the same, and there was a little difference in cost towards CTA, but we all know that this very much depends on the cost of CTA and the reimbursement in different countries. So the other thing, the heart score that Faisal mentioned, there have been some studies looking at it. It's mostly applicable, been utilized in Europe, but if you noticed on the other one, it's not the typical heart score. They're using a modified one in the US because the heart score, the initial one, did not perform that well in the US cohorts. So we'll wait for the final kind of score to see which one would be applicable in our type of patient settings.
Any other comments? Yeah.
What do you think should be, if any, the best approach to try to reduce repeat visits? I mean, you have to give the patient an answer as to what the cause of the chest pain is.
You know, I am so happy you asked that question because I had it in my mind to bring it up and senior moment, I forgot. You're right. See, people come here or they go Herman or they go anywhere else and they get this $1 million workup and everything is normal. But then 4 months later, they go to another hospital and they get a $1 million workup again. So A, cause, B, radiation, if they're getting more than one CT, more than one nuclear stress. So this problem that's also a very important problem, which we might not be able to completely eliminate patients getting scared and going back to another ED. But if we could do a protocol that is less costly and less radiation and all that, then at least it's safer for the patient and cheaper. You know, people are what they are. I mean, I have patients that I have reassured them 100 times they have had everything, and they still get scared when they have chest pain, and they still call. Unfortunately, human beings are human beings, and the chest area is a scary area for many patients. But I think your point is very well taken. This recurrency of people going back to an ED, and they don't always go to the same ED. They switch. So that's a very good point. Sumin. Get closer, you cannot hear you.
How come, you know, they are alive, right? But then we're just kicking the can down the road. We still haven't provided patient any answer. So it's always saying, okay, you're safe to go home. Patients still need to go to get a primary care doctor, a cardiologist.
Oh, absolutely.
Yeah, so.
And that, by the way, that is probably a very important difference between the European model and ours. Because in the European models, probably is a higher chance that patient will follow with some sort of primary care doctor, and then will grab that information, and then will work with the patient to do other things. Where here, people frequently go home and disappear. So your point is, and that's, by the way, that is one powerful advantage of the calcium score. Because at least they're going home, you know, let's say that they have a positive calcium score, and you observe them, and then you do more testing, and everything is fine. But now they're going home with a whole different set of guidelines of what they need to do for prevention that they wouldn't have had if it had been just simply a normal enzyme or whatnot. So your point is well taken. Yeah. You're good.
Along the same lines of arranging for follow-up for these patients, what do we have within the Methodist system where if we send the patient home, because I have this conversation very often with my husband, who's an ED physician here, sending the patient home, and the discussion is how fast can we get them into cardiology? The wait times are long.
But what do they need to see a cardiologist? Let's say everything was fine and everything was negative. Why do they need to be seen by a cardiologist?
I think, as you said, the human nature, recurrent chest pain, and the discomfort. I believe most of our patients, when they come from primary care and they come to our clinic, they get some form of reassurance. And it's not unreasonable, in my mind, if a patient is continually having chest pains to get checked out.
How many of these patients, Steve, in Canada, go to a cardiologist? If everything is normal in the ED? They go back to the primary care. Yeah, they go to the primary care doctors. Yeah.
I think this is a great discussion, Al. I think we have an opportunity to do something here at Methodist. There is a chest pain committee that actually I've asked them to relook at all of our protocols and see what we do, because nowadays with Epic, you have a drop-down menu as to what you want to do in the ED or beyond the ED, who are the patients that need to be admitted to OBS and being observed versus others. So Faisal, I know you're going to be on it. But I think this is very important for us to currently, nowadays in 2019, how is the best way to do it? They're going to use one of these algorithms, at least from a clinical point of view and a troponin point of view, to help. So we're going to do that. And the question is, where does imaging fit into the equation? How do you see patients, and how do you, I mean, that's a big issue here as opposed to Canada, where actually there was a study where somebody sent out from the ED, they already have an appointment for either a treadmill, if they're say, or further diagnostics, because if you do the screening and the screening is negative, you're still gonna find out whether this is, ischemic heart disease, yes or no, if they have risk. So some imaging at some point in time, stress testing will be needed. So this is time for us to do this. And for your information, coming to the ED is costly. And if you, you can end up, now this is what's billed, part of it is insurance, et cetera, you can end up between $8,000 to $15,000 just having this kind of workup with an ED visit, a stress nuclear, and whatever it is. And this is not small change.
Yeah, because remember, most of these patients are outpatients. Even if they stay 24 hours in op, they're outpatients. And many of these insurance company systems have, my daughter, they have $3,000 copay per member of the family, not for the whole family. So there are two kids, husband and wife, each one has a $3,000 copay. So at the very least, $3,000 are out of their pocket. And that's the way most insurance companies are going nowadays. Yeah. Good discussion.
Great.
Thank you all.